So I've got a few kind of slides later on just to kind of make it a bit more interactive. So it's all via Slido. Hopefully it will work fine. It worked fine earlier on. We'll do our best. If it doesn't, we'll, as a small group, we can just shout out. That's fine. But as I said, the main thing is to make you more comfortable with these types of medications and changes you might see in the community setting. So just briefly, I don't have like you could talk literally for weeks on what the difference is between the different inflammatory bowel diseases, the main two being ulcerative colitis and Crohn's disease. But this is just a table that gives you the main differences between the two. But just to explain briefly, they're both an autoimmune disease of the gut. They both cause inflammation of the gut, but ulcerative colitis, the inflammation only occurs in the large bowel or the colon, hence the picture there that's in kind of orange and red. And it's in the top layers of the mucosa, so it doesn't go trans through the mucosa. Conversely, Crohn's disease can be inflammation anywhere in the GI tract. So I can go all the way from mouth down to anus. And the ulceration and the inflammation actually goes through all the layers of the mucosa. So that's not to say that Crohn's is worse than ulcerative colitis. It's just that's how they're different, and that's sometimes why they're treated differently. There are other differences with regards to kind of signs and symptoms that you might see. So ulcerative colitis is characterized mostly by watery, bloody diarrhea. Whereas Crohn's disease can have diarrhea, there can be blood, there can be mucus, but most patients find things like abdominal pain more of an issue. Also, because of sometimes the symptoms of things like obstruction within the gut that happens commonly in Crohn's, they can get symptoms like nausea and vomiting. So while they both can come under the umbrella of inflammatory bowel disease, they actually are quite different and they can come with different symptoms. And actually, you'd think therefore they're quite easy to determine between the two. Actually, sometimes patients get classified as IBD unclassified because they have aspects of both ulcerative colitis and Crohn's disease, and so that's important for treatment as well, because we kind of have to treat them as if they're the two diseases in combination. And sometimes, just to make things extra complicated, patients can initially be diagnosed, say for example with ulcerative colitis, and then later down the line with more imaging and more investigations, they realize it's more likely to be Crohn's disease, so that there can be a changing between the two conditions as well. But that's just to kind of give you a brief overview. So how could a patient present to yourself in community? And in my head, I was thinking, well, they could either be undiagnosed or they could be diagnosed and their diagnosis could be new to them, or they could be long or longer term. And all of them really will still follow this same pattern in that they'll get symptoms, and depending on what their services are, depending who they speak to, they will get a diagnosis. But that symptom to diagnosis process can be very variable with regards to time, length, etc. And then once they've been diagnosed, whether it's, as I said, ulcerative colitis, Crohn's disease, or possibly IBDU, unclassified, they will then get management. And there's an initial management, and that's normally to treat the flaring symptoms. So as I mentioned, things like bloody diarrhea, maybe abdominal pain, and then we'll try and put them onto maintenance management to make sure that doesn't happen again. But unfortunately, both the conditions of IBD are what we call a relapsing remitting disease. And what that means is that patients will often be okay, and then unfortunately their symptoms tip over and they go back into a flare situation. And then we have to pull them back from flare back into maintenance to make them go into remission. And so patients can be on this cycle. So they think they're fine, and then unfortunately they get unwell with their symptoms again. We get them back into maintenance, and then they can be okay for a little while and go back into a flaring condition. And it's often seen that the more they flare, the more likely they are to have complications and need things like surgery in the future, or quote unquote harsher medications. And I'll talk about those in a moment. They might need more steroids, and they might need like inpatient stay, which obviously is not good for anyone if it can be avoided. So the whole point really of these medications is to stop that up and down, relapsing, remitting, and to try and keep them on a nice, stable, even keel and keep them in maintenance. So, if the patient, and what I'm going to do is talk about a patient the whole way through, like a journey. I haven't given them a name, I've just called them patient X, but I was just thinking about if they were undiagnosed, how might they present to you? So, as I said, the main symptoms are normally diarrhea, abdominal pain, more so if it's Crohn's disease, blood in the stools, mouth ulcers, bloating, and constipation. And you're probably thinking, well, that could be an absolute number of things. And that's the problem really with IBD, is a lot of the symptoms look like other conditions. So I guess if you have a patient coming to you with these sort of things and you've done all the usual things, maybe start thinking maybe there's a problem here with IBD. They also can get extra intestinal manifestations. And what that means is inflammation outside of the gut. Again, it happens more in Crohn's disease than it does in ulcerative colitis, but it still happens in ulcerative colitis. And across the board, about 50% of patients with inflammatory bowel disease will get these inflammation symptoms that are outside of the gut. And these are just a couple of the options here. So the first thing is they can get inflammatory arthritis. The second is erythema nodosum. And the way I describe this to patients is like having half a Malteser underneath your skin and it's bright red. So it's hard, solid lumps. And they're often found in places like the forearms and the shins, but they can be other places as well. So that's a skin inflammatory condition. There's also pyoderma gangrenosum, which, if you haven't come across that before, it's ulceration of the skin, and often it's seen like kind of little black dots, and they can be anywhere on the skin. There's also primary sclerosing cholangitis, and that's a type of liver condition where the bile ducts are inflamed, which causes a backup of bile, and so cholestasis, and that can then cause further liver damage. And also inflammation can annoyingly for the patients be caused in the eye. Commonly uveitis is the one that's seen. I rarely see iritis and episcleritis, but that is where you get a dull throbbing in the eye, and they can result in visual changes. It can be very painful, can be very red, and they often need steroidal drops and lubricating drops to review, but this has to be diagnosed by either an optician or an ophthalmologist. So we're very lucky in Brighton, we have an eye hospital. Others would have to go via their GP. So that's extra intestinal manifestations, so inflammation outside the gut. And then other things that can happen is delayed growth, especially in children. And that's because one of two reasons, really. They're not absorbing nutrients from their food because of the transit of the diarrhea all the time, but also that they might be on steroids to treat their symptoms. Patients can have weight loss. Again, because of the diarrhea, and often because the diarrhea is linked to certain types of food for them, they get a reduced appetite. They can get lethargic, again because they're not absorbing the appropriate iron components that are required, but also because anyone, as you know, with a chronic condition, fatigue is a major concern. And they can also get fevers and night sweats. So this whole picture, I think you'd agree, looking at that doesn't scream it's definitely IBD when you're looking at kind of the main and the others, but possibly the extra intestinal manifestations might point you in more direction that it could be IBD. So if someone had the main ones and maybe joint pain and they were very young and hadn't had injury, that could be something to consider, for example. So if we consider all of those, what might it be other than IBD? And you yourselves will know this a lot better than I do, because I deal with IBD and autoimmune diseases of the gut. I don't deal with everything else. So you'll already be thinking these things, I'm sure. But it could be a general infection. They could have picked up something if they went on holiday, for example. It could be irritable bowel syndrome. And actually, a lot of our patients, don't understand to begin with that inflammatory bowel disease and irritable bowel syndrome are two different things, and also that they can coexist. So you can have both of them. So we could sort out all the inflammatory bowel disease so we can get inflammation of the gut under control. But if they're not taking IBS medication, so the antispasmodics and things like that, they'll still be getting symptoms. So sometimes we need to ensure that we're treating both. Other red flags, I'm sure you're aware of, are things like colorectal cancer, ovarian cancer, and endometriosis. And something that happens a lot with any autoimmune diseases really is celiac disease. So if you've got one autoimmune disease, you're more likely to have other autoimmune diseases. And because diarrhea and other gut problems occurring, celiac is often a problem as well. So it's a thing to consider. So what I would say is if you're having patients coming in and they're repeatedly asking for anti-diarrheals, anti-bloating medication, antispasmodics, things like that, then and laxatives as well, because some patients, even though diarrhea is a main concern, some patients do get the constipation, do have IBD in the back of your mind. So I just wanted to talk a little bit about like, okay, so you've got IBD in the back of your mind, but how do you know that the patient has IBD apart from just having the symptoms? And one of the main ways is something called fecal calprotectin, which is a protein when there's inflammation within the gut that gets shedded from the mucosa into the stool. And so this can be tested really easily on a stool sample, which obviously no one likes to do, but it's nicer doing this than having to do things like colonoscopies and MRI. So it's a good first step to try and differentiate if the patient has inflammatory bowel disease. So for people that don't have inflammatory bowel disease, a fecal calprotectin level of up to 50 is absolutely normal. So if I did one today, I could have it up to 50 and no one would bat an eyelid. Interestingly, the goalposts for what is okay are slightly moving. So it used to be about less than 150, but now trial data really show that if you've got fecal calprotectins of less than 250, that's showing a response to treatment. So that's why I've put okay kind of in inverted commas there, because it just depends on what trial you're looking at. But I believe when you're seeing anything above normal, they do ask you to refer that to either the GP or the specialist centre. So I imagine anything above 50 has to get referred from community. But we start to really worry when it's a little bit higher than that. When showing higher levels of inflammation is definitely over the 300s, and over 600 is showing high levels of inflammation. But the thing with this is we have to take it with a bit of pinch of salt, really, because for example, a patient that's over 600, we don't know if it's 601 or 4,000. And so if we put them on treatment and it was originally over 4,000 and it got to 601, that would show a really good response in treatment. But according to the trend, it would still show that they're really having lots of inflammation. So that's why we don't just use fecal calprotectin biomarkers as our only way of assessing patients. We still talk to them, we still review their symptoms, and we do look at other imaging like colonoscopies and MRIs, etc. But conversely, if I had a patient that was always really good with their fecal calprotectin and it was around 100 and it suddenly went up to 600, I would be very concerned about that. So it's about trends and thinking about the whole holistic picture. So our patient X, now they're thinking, oh, they might have something a bit more than traveler's diarrhea. These symptoms have been going on for quite some time. They're really struggling. Let's get some investigations being done. So the first thing that GPs are requested to do is to do a fecal calprotectin. And in this instance, I've said that they do have a high level of inflammation. And on that, they would be referred to their local gastro team, of which I'm part of. With a fecal calprotectin of that, they would definitely order, this team would definitely order a colonoscopy. And they would likely order an MRI too. MRIs take a bit longer to get done. So the colonoscopy is normally done, and then the patient's normally awaiting the MRI. And for the sake of this example, you can see normally in the scope whether the patient's got ulceration or not. And so you can call it's likely to be IBD at that point. And it depends on where it is, but I'll come to on what type of colitis it can be. But for the sake of this patient, we could say it's pancolitis, which means it's inflammation across the whole entire colon. But they would still take biopsies to see if it's that top level inflammation or if it's going transmural, to try and see if they could work out if it's ulcerative colitis, so top level, or Crohn's disease going through the strata. And they would do an MRI as well to see if it's happening outside the large gut, if this inflammation is happening outside the large colon, if it's going into the small bowel, because a colonoscopy can only do the large colon and sometimes can't even do the whole of the large colon. It depends on how inflamed the colon is, how much pain the patient's in. and how good the preparation. So is there a lot of stool still in the bowel, etc. But based on this, if from a colonoscopy they could see ulceration that looked like IBD and fecal calprotectin over 600, they would have a working diagnosis of IBD, probably ulcerative colitis, but we're going to await the biopsies and the MRI to determine either way. So it's all well and good getting a diagnosis, but we need to treat this poor patient because, they're feeling absolutely rubbish. And some of our patients, they go to the bathroom literally 20, 30 times a day. And you can imagine just running back and forth, that would be exhausting. But obviously the pain that's associated with that, the embarrassment, etc. So we want to get them some management with regards to that. So what do we do? So this is a really simplified version, and that's not to be patronizing. It's just this is the easiest way to explain it, really. And we literally look at, first of all, does the patient have ulcerative colitis or Crohn's disease? In patient X, we're not really sure, but we think it might be ulcerative colitis. So we would go down the ulcerative colitis route, which is on the left-hand side. If we definitely thought it was Crohn's, we would go on the right-hand side. And if you're sharp-eyed among you here, you can see that there's not much difference really between the ulcerative colitis route and the Crohn's route. The main difference is that in ulcerative colitis, we use the aminosalicylics, which are like your mesalazine, your sulfasalazine. To be honest, we rarely use sulfasalazine anymore. It's quite an old-fashioned drug. We'd be using the mesalazine products, and we'll come to what those are very shortly. And that's the main difference. If you're diagnosed with definite Crohn's disease right at the beginning, the evidence for mesalazine now for Crohn's disease is very low, so we wouldn't start patients on mesalazine in Crohn's disease. But if we think there's an inkling of ulcerative colitis while we're waiting for all the other information, we would definitely start them on a mesalazine. And we're also likely to give them steroids, and I'll come on to those dosings in just a moment. And then these circles, because everyone thinks, oh, well, it's all done by the specialist team. Actually, what can the community team offer for these patients? And actually, I would say an absolute lot, because there are ways that the community team can help with mesalazine optimization. They can help with steroidal, not just the dispensing, but making sure it's the correct dosing and they're getting all the supportive medications. And then there's other information about medicines optimization very shortly, which you can get involved in, or even if you don't want to get involved in but you're concerned in, you can flag and the specialist team can get involved in. So onto steroids quickly, because that's normally what we use first line if a patient is really symptomatic like our patient is. And steroids provide generally a good effect, but they are not in any way a cure. They just provide a short relief. And the problem we have with steroids is generally they're very effective for our patients, and the patients just want to take them. They often don't want to take the other medications. But the problem is the more you use them, the less effective they become. And as you know, I'm speaking to a room of healthcare professionals here. Steroids come with an awful lot of side effects as well. When we are using steroids, whether it's for ulcerative colitis or Crohn's disease, we need to ensure that it's not infective. So along with the fecal calprotectin, we do an infective stool screen, because obviously if we're giving someone steroids and they've got an infection, that's going to make it a whole lot worse. So as long as they're not infective, then we can give them steroids. And this is the guideline that we have within the hospital. So I've just put it up for completion. The inpatient treatment is on the right-hand side, which is the hydrocortisone IV. But what you'd be seeing in community is the oral prednisolone. And the dose is pretty high, and it goes on for quite a while, a lot longer and a lot higher than you see for things unlike like respiratory or some skin conditions. So we recommend prednisolone 40 milligrams in the morning, reducing by 5 milligrams per week. And so that's a total of 8 weeks minimum. We do have some scenarios where patients have it for a 5-day reduction, but to be honest, that's very few and far between. It's generally 40 milligrams and then reducing by 5 milligrams per week. And unless it's contraindicated, we always give Adcal D3 or a similar product alongside it while they're on the prednisolone. We don't always give a PPI. We only give a PPI if the patient does have signs of gastric acid reflux, or if they've got risk factors for them. Because again, as you know, some patients, they get put on PPIs and then they never come off them. So we try to make sure that we're not adding to that problem. What we do find is GPs are very keen to help with this, or any other non-medical prescriber, and they will prescribe prednisolone, but they often don't prescribe it high enough or for long enough. So we often see patients being prescribed 20 milligrams a day for 5 days, and that's it. So, it's great that something's being started, but we do really need to go in with these higher doses. So I would say, again, if there's any concerns, just check with your local specialist team. Also with steroids, I mentioned there's that whole relapsing, remitting event of IBD. And so we expect patients to unfortunately relapse. That's going to be part of their condition. But what we're concerned about is if patients are getting more than one course of steroids a year, then we really need to step up the background treatment to make sure that they're not needing these steroids so often. So again, if you're noticing that for this indication, do refer to the GP to make sure they're referring back to the specialist team. And interestingly as well, and you'll probably see this with other conditions, when steroids are withdrawn, if the patient has become very reliant on them for symptom control, the withdrawal of them can often mirror IBD symptoms. So they're saying, oh no, my IBD is not controlled. It's actually not the IBD, it's actually steroid withdrawal. So then we have to deal with that and put them on a kind of a specialist reducing regime. So again, that could be part of the problem. That's not something for you to deal with. Do refer back to the specialist team, but it's just to make you aware. This is just for reference. Yourselves know this. It's just part of the slide deck. So I've kept it in there about the side effects of steroids. You might see some alternative steroids as well being used. The one that we have in our formulary in our hospital is budesonide, and we use that both orally and rectally. And there are different brands for the different types of IBD as per their licensing. And then there is the budenofolk foam, which is the budesonide foam enema. For budesonide oral, it's 9 milligrams once in the morning for 8 weeks. The information in the SPC says a taper can happen, but in our experience, we don't often have to taper. So it's a really convenient way for the patients to take the medication. And why you'd use budesonide over prednisolone is if patients are particularly concerned about side effects of prednisolone. So if they get lots of kind of mania or other mental health concerns, if they get a lot of weight gain, some patients have real problems with their skin, the whole gambit of prednisolone. So we use budesonide in that case. Budesonide is effective for controlling the flare, but sometimes it's just not enough. So we normally give it 2 to 4 weeks, and if it's not worked, then we escalate it to the prednisolone. And again, we discuss that with the patient. The rectal budenofolk foam, we can use that on top of using the budesonide or prednisolone orally. That's absolutely fine. And that's just one enema once a day. And again, I'm going to come on to the rectal products in a moment. Other steroids you might see, we don't use beclomethasone within our trust clipper, and that's just because NICE has shown that they're equally effective, both beclomethasone and budesonide in the case of IBD, and so our formulary just asked for us to do one. So we already had budesonide on formulary, so nothing other than that. That's the reason, but you might see that, and so the doses are up here, but I don't have lots of personal experience with that. So back to our patient and on the starting of management. So already we've got a big tick. We've got them on steroids. We've optimized that to try and give them symptom relief. The next thing we would do is put them on mesalazine. Now, when I say the next thing, I don't mean we'd wait for the steroids to complete. We'd start it at the same time, but just the next thing I'm going to talk about. So again, just because we're healthcare professionals, I've put this up here. I'm not going to go through this, but this is just the mechanism of action if you want to know. But in brief, they inhibit all of the inflammatory markers, and it promotes the kind of the free radical type things that you want to promote healing and reduce inflammation. So the first thing is mesalazine adherence important? And this graph here shows really how important it is. So the blue line along the top shows adherence. The orange line that's dramatically going at a 45-degree angle shows non-adherence. And what this is showing that if a patient continues to take their mesalazine, if they've got ulcerative colitis, not if they've got Crohn's, they're likely to stay within remission for up to 2 years at around the 85% mark. Whereas if that same group of patients didn't take the medication, over 50% of them would have relapsed over the same time period. So a little bit like your antihypertensives and your preventer inhalers in asthma, taking something that is prophylactic is really important, and it will stop that relapsing event. So it's really important to tell the patients you might feel well now, but actually if you don't keep continuing to be adherent to this medication, you're likely to relapse and need all of these interventions and cause yourself problems. So it is really important. So I've talked about mesalazine. Let's talk about the mesalazine types. You'll probably know all of these. So the first lot is there's a whole array of tablets. It feels like sometimes the tablets are as big as they show on the screen. The patients are always telling me how huge they are, but we've got a whole array of different brands. They've also got suppositories, and we have enemas too, both foam and liquid. So how do we decide which ones to use? And we decide really by where the inflammation is. So the patient I was talking about earlier on, that's pancolitis. That would be whole colon, so the very right-hand side of one. But I'm going to start on the left and then work my way to the right. So proctitis is when the very end of the rectum and anus is inflamed. And really, if it's the length of a suppository, then a suppository is probably going to be fine for these patients, which would be great because it means you're not taking something orally, you're getting reduced side effects. You know all the reasons why suppositories are great. The problem that we have generally in this country is patients don't like to take rectal products. Again, you might have come across that in your own practice. When I speak to my colleagues that work in Europe, completely different situation. Actually, patients much prefer rectal products, so the uptake is much better. But in this country, generally not so much. But with IBD, I would say our patients are more willing to take or use rectal products because they're aware of the condition. When we explain to them, it means that you're not going to have to take a tablet, so you're going to get less side effects. We can normally convince them. So if it's at the very bottom of the anus and rectum, that's called proctitis, and hopefully it can be controlled with suppositories. If the inflammation goes up more, so it goes along the sigmoid as well, it's called procto, so anus and rectum, and sigmoiditis, so the combination of the two, and the red bit in the diagram kind of illustrates that. So you would still want to use suppositories because you want to get that end bit, but you can now start to introduce enemas into there to try and get further up the colon. If the inflammation goes even further, again, you would still want to use suppositories because the enema is going to shoot straight past it, plus an enema, but you might start looking then at adding in oral medication as well. And if it's the whole colon, there is not an enema anywhere that's going to get all the way around. So basically, they only go up to the flexure where it starts the descending. So on your screen, the very top right-hand side of the bend there, that's the start of the descending colon. So your enema, if you're lucky, will get maximum up to there. It won't go along the transverse colon or the ascending colon. So you're definitely going to need oral products. Hope that makes sense, because that's basically the key on how you decide which products you're going to use. Mesalazine also has had lots of trial data looking at the pharmacokinetics of it. And I'm sorry if anyone's red green colorblind, but this was the only one I could find. I think that's because obviously pHs are normally done in reds and greens, but the pH is there. But you can see, obviously, we go from a very acidic pH in the stomach all the way down to a much more alkaline pH as you go further down the colon. And what it shows is that the different types of mesalazine dissolve at different pHs, with the exception of pentasa granules, which are time dependent. And this then might be relevant for which part of the colon you're trying to target, or the very top or start of the large bowel and colon, or the very end of it. This is obviously absolutely scientific fact, but what I would say is on the majority, it doesn't seem to translate well to patients. And what I would say is the most important thing to choose from mesalazine is target whether you're going to use suppositories, enemas, or oral. What's on the formulary, because obviously we're all governed by that. The pill burden for patients. So some patients find taking those really big pills really difficult, and so you might want to switch to granules. And also something called ghosting. So some patients, the transit is so quick that the medication doesn't get enough time to be absorbed when it's in the solid form of tablets. So again, the granules might be helpful. Another time, though, just to go back to this, where granules are really helpful is again if they have distal disease, and distal disease is when it's kind of closer to the rectum or anus. So any distal disease tends to be better treated with granules as well. And then one final thing with mesalazine is it's really important, and it's within the BNF, that you have to prescribe it via brand if it's oral, but if it's rectal products, completely interchangeable. So that's really important to know for kind of your formularies and prescribing practice and dispensing. So this patient, as we mentioned, is on steroids, they're flaring. So we want to go in with like a flare treatment strategy to begin with. And what we do is we basically double up on what the doses are as a standard maintenance treatment. And we'll often give them a top and a tail approach. And what top and tail means is that you get the oral, but you also get rectal as well. And you're allowed to do that within, you don't have to do like a cumulative daily dose between the two of them. You can do max of both oral and rectal products if the patient will use rectal products. So within our trust, and again, I know I'm speaking to across a wide area, so I can only speak for the Brighton area, but the formulary option is Octasa. It might be different from yours, and the maximum dose for that is 4.8 grams daily. Or Salifalc granules. So again, we would use Salifalc granules if the patient is having trouble with the tablets or they have that distal disease. And the maximum dose, because it's granules, so it's a different formulation, is 3 grams a day. Other patients will be on different brands, and if they've already been starting on those brands, we continue with that because it has to be brand specific. But as you know, Azicol and Pentasa have been kind of up and down in the market, so they might not be able to get them available now or for much longer. And then the rectal products that we put in, as I mentioned, if it's proctitis only, they get a suppository, so it's 1 gram. If it's more extensive disease, so remember those red diagrams, then they would get a suppository plus an enema on top. So quite a lot of mesalazine going on, but we really want to kind of hit it hard and strong. And how long they take it for is basically 4 to 8, I've put 6 there, but 4 to 8 weeks after symptom improvement is seen. So a lot of patients, they see symptom improvement and then they just stop taking these big doses. They need to continue taking them for, as I said, 4 to 8 weeks after that symptom improvement, and only then can they reduce down. And then what do we reduce to? So we're trying to reduce to maintenance treatment. And like all things, we want to have the patients on the least amount of medication that's controlling their disease. And so maintenance treatment, again, using the same drugs that I would use before. So if you've got a slightly different formulary, just amend. We would go down to Octasa 2.4 grams a day, or Salifalc granules 1.5 grams a day. And the quick ones among you would realize basically just half the dose and you take away the rectal product. Some patients, when you reduce them down to these, their symptoms do come back up. And so I just increase them back up. And sometimes they always have to be on those higher, quote unquote, flare dosing, even if they're not in flare. These are very inert drugs. This is not the end of the world. I'd rather them be managed on these higher doses than needing steroids repeatedly. But generally, we're trying to get them on the least amount as possible. These basement doses of 2.4 grams and 1.5 grams daily, as on the screen, these are due to the cancer protective effect. So we generally don't go lower than this if possible anymore. We used to in the past, we don't now. And then again, this is just an example from our trust, but we have a self-management plan. So for our patients, so we say, you know, if you're doing really well, but then suddenly your symptoms worsen, what you can do is self-escalate. So you were on Octasa 2.4 grams a day, for example, you start getting all these symptoms. Please do just increase your mesalazine up to 4.8, take it for 6 to 8 weeks. And then once you're feeling better, you know, after you're feeling better and you've taken it for that length of time, 6 to 8 weeks after, you can reduce down. And if there's any problems, do contact the helpline. So this is what we call like a self-management plan. With regards to monitoring, they're contraindicated in salicylic allergies, which makes sense because of the cross sensitivity. They, as I said, they're pretty inert drugs, which is brilliant. The only problem really is they can cause nephritis. So if a patient already has renal problems, I wouldn't recommend that you start them on this if they've got renal impairment of less than 20 mils a minute. And in your monitoring, if you notice an AKI developing, again, to stop them is alazine. Within the SPS, the monitoring is quite extensive, and I can't say in hospital that we do this level of monitoring, but obviously I know I'm speaking to community teams, so I don't want to give you kind of incorrect information. This is what they say, but I know in hospital we wouldn't do this level of monitoring. But what you're looking for really is looking for, as I said, the renal function, and then just checking, because there is a slight concern that there might be a DILI, that there might be some myelosuppression, but genuinely I've rarely seen that in practice, but you look at the whole gambit of bloods. So back to our patient. So initially we gave them prednisolone 40 milligrams and we're going to a day, and we're going to reduce them by 5 milligrams a week, and that's 8 weeks in total. We'd have given them Adcal D3, 1 tablet twice a day while they're on the prednisolone, unless they're already on it from the GP. We wouldn't double up, and we'd start Octasa 4.8 grams a day. Further test we're waiting for. So the biopsy came back, did show it was ulcerative colitis. That's good news. We don't have to change anything at this moment. And the MRI showed that there's no inflammation elsewhere in the small bowel, so it's unlikely to be Crohn's disease. So the working diagnosis is definitely ulcerative colitis. As I said, that can change in the future. And so the plan would be to continue reducing the prednisolone as we have, continue the Octasa, but hopefully to reduce it once they're more settled. And then need to be a specialist team follow-up. So again, we're not expecting the community to do this. This should be done with the specialist team, but we know what waiting times are. So again, if you're not seeing this happening, do contact the specialist team to chase. And then kind of holistic things to tell the patient, just in case they're ever asking, what should I do? With IBD, always avoid NSAIDs. And that's for kind of pain relief. Small dose aspirin, if needed for cardiology problems, isn't a concern, but it's if they're using ibuprofen, aspirin, diclofenac for pain relief, that can worsen ulceration. It can actually push people into having IBD. Often patients feel very fatigued, so they might need a fatigue follow-up, and that doesn't have to be done at a hospital. That's a standard, anemia screen, so that can be done in community. Patients often are worried about food, so we recommend that they keep a food diary to see if they've got any triggers. And normally, the more controlled their disease becomes, the less triggering food becomes. And also, the main patient charity for IBD is Crohn's and Colitis UK, but it's not just for patients. It has such great information there for healthcare professionals as well, so I would really recommend it. My Slido doesn't seem to be working on my other screen, so I'm just going to go through this. I do apologize, but I'll explain for you. So if patient X was having a flare a year and a half later, what would we do? So the first thing I'd always suggest is, first of all, ask the patient what exactly is happening. So just to catch you up with this patient, they'd have completed their prednisolone. They were able to get down to their Octasa 2.4 grams a day, and their fecal calprotectin was improved. So, win-win everywhere. But unfortunately, they've come back to you with bloody diarrhea, abdominal pain, and feeling very fatigued. So the first thing I'd say is get a stool sample to make sure that it is IBD related and it's not something else. And are they being adherent to their medication? Fecal calprotectin, again, for argument's sake, I just said it came back at over 600, but anything of an increase over 100, I would be concerned, because, it was appropriately stable before. And often what we see in patients is they say, actually, I was feeling really well, so I just stopped the Octasa. And that's generally the reason why. So what I'd suggest we do is we restart the Octasa. Because they're in flare, they would need to go back to that higher dose of 4.8 grams a day, continue 6 to 8 weeks after the symptom improvement, and then look to reduce. And depending on how unwell they feel, we might want to restart another course of steroids. And again, because they're feeling fatigued, is it because of the flare, because it's exhausting, or is it because they've been losing lots of blood and so they might be anemic? So to do anemia review. However, so that's the first case scenario. What about though if our patient actually, same situation, they have a raised fecal calprotectin, but when you ask them about adherence, they said they stopped not because they felt well, but because they didn't like taking the tablets, because they are like horse pills, they're huge. What can you do then? So I've kind of already alluded to the sort of things I would recommend, and that's, you could switch to granules. That might be a really easy thing to do. The other thing you could do, and patients aren't aware of this, is it's been proven that once daily dosing is as effective as twice daily dosing, as effective as three times a day dosing. So if the patients find it easier to take it all in one go, then you could just change it to once daily dosing. If actually they prefer to split it up, you could do that. So anything really to help with their adherence. But if that doesn't work, you can switch them to granules. Again, we'd need to make sure they're on that max dosing and look to continue until the symptom improvement, and then 6 to 8 weeks afterwards. And again, we might need steroids, and again, we might need the anemia review. So again, finding out why they're not adherent is really important, because if they say they're not taking it and we don't know why, and we just keep prescribing it and they're still not taking it, it's not going to make the problem go away. What about though if the same patient has the same situation, their fecal calprotectin is still raised, they're still feeling awful, but they are adherent to medication? What do we do now? So because they're on Octase 2.4 grams a day, the first thing I would do is increase their Octase up to maximum dose, and I would add in rectal products. And because it's pancolitis, they're going to need the suppository and the foam enema. Again, continue as before. They're probably going to need steroids while we're trying to sort it out, and an anemia review, but I would be thinking I need to refer them to the specialist team, because really you've done as much as you can. You know, you've made sure they're adherent to the medication, you've maximized the medication, and they're needing steroids. So let's refer them to the specialist team. Same patient now, but slightly different. They've continued their mesalazine, but they can't reduce down to that maintenance dose. They're still on that flare management dose, which, as I said to you before, isn't a problem. You can be on that. It's not a problem, but it means there's nowhere to go as an escalation policy. And also, unfortunately, they tried to reduce their prednisolone, but as soon as they went below 20 milligrams a day, their symptoms worsened, and their symptoms were bloody diarrhea, abdominal pain, feeling fatigued. Now, I did mention that reducing prednisolone can, or withdrawing can, actually mirror IBD symptoms. Doesn't normally happen on a once-off. It normally happens when patients have been on steroids for a very long time. So in this scenario, I don't think it's due to steroid withdrawal. And then if you do a fecal calprotectin and it's over 600, then you know it's due to flare. So you can tell they're adherent, they're on the max doses, they can't get off their steroids. So absolutely what they need to do is referred to a GP specialist team straight away. They're likely to need a steroid extension. So whether that be a dose increase and then reducing slowly, or back up to the 40, or back up to the dose where they were last well. And they're likely going to need now an immunomodulator therapy. So the next stage in treatment, which is started again with the specialist team. And as a reminder, anyone that's having more than one course of prednisolone a year, or if they're having extensions of prednisolone courses in the year, refer them to the specialist team. So back to our patient and our pathway. They've got ulcerative colitis, we know that. We've optimized their mesalazine as much as possible. We're giving them steroids. So what else do we have to do? And that's looking at the next level of medications. So you are not meant to see this. This is just to highlight how complicated the immunomodulator pathway, which is the next step of medications, is. I'm currently updating it. We're very lucky. There's always new drugs coming to market, and they seem to be being NICE approved, but it makes pathway development quite tricky. But it's really complicated, and that's why it's done by specialist teams. So it's not an expectation that you ought to know this, but I just wanted to give you kind of an overview of the ones that you'll see in community. And those really are the thiopurines, which are azathioprine and mercaptopurine, and sometimes we use methotrexate if the thiopurines aren't tolerated. In ulcerative colitis, we would continue the mesalazine and add in an advanced therapy like thiopurine. And that's if it's mild. If it's severe, then we have thiopurines aren't advanced therapy, they're immunomodulator therapy, and that's for mild to moderate. If it's severe, then we would add in an advanced therapy, which are the standard and traditional biologics, so things like infliximab, and we might do a combination with thiopurines for that. So for ulcerative colitis, you always continue the mesalazine throughout, as long as it's not the patient isn't intolerant to it. If it's mild to moderate, and it's not being controlled by the mesalazine, they would have in thiopurines added in, or possibly methotrexate if thiopurines aren't tolerated. And if it's severe ulcerative colitis, again, the mesalazine is maintained, and then they're likely to go on to things like biologic therapies with possibly thiopurines alongside. And obviously, as I mentioned, the things that you see in community are the thiopurines and methotrexate. Advanced therapies are all done by the hospital. So patient X advanced management, we're going to continue the mesalazine, but start thiopurines, and then we'd organize a shared care protocol once we've loaded them. Now, how does that all work? So the first thing to know is we do a full workup of these medications for the patients, and the dosing is dependent on an enzyme called TPMT, and the dosing's up there. And again, I don't want to say this is hard and fast rule, because it might be slightly different policies depending on centres, but certainly within our area, we do azathioprine dose if the TPMT is in range of 1.5 to 2 milligram per kilogram per day, up to 150 milligrams a day at first. And then we'll increase above that depending on levels. So you commonly see a max of 150, but then you'll often see patients going slightly above that as per the levels. And mercaptopurine, because of the way basically azathioprine gets broken down into mercaptopurine in the body, and mercaptopurine is what does all the anti-inflammatory stuff. So because of that, you need less of mercaptopurine, and it's roughly half the dosing of azathioprine. Azathioprine is our first line, but we do use mercaptopurine, and we use mercaptopurine when patients are intolerant to azathioprine, because often if they're intolerant, actually switching them helps. And intolerance is often seen for things like nausea, vomiting, always feeling very flu-like. Those can definitely happen for the first 2 weeks, but they should be mild and they shouldn't affect the patient's quality of life. But if it's really bad, then it's likely to be an intolerance to azathioprine, so we can stop it and then restart them at mercaptopurine. The reason we don't use mercaptopurine first line is because it's more expensive than azathioprine, and you know the reasons for that. So I was thinking of common issues that you might see in community, and I came up with these things. Again, you can ask me some questions if I've missed any. So I'm just going to go through these briefly. So the first thing, blood's going off. If it's for all of them, really, what I would say, especially if the patient's been on the medication thiopurine for a while, consider recent medication changes. We recently had a patient who was very stable on azathioprine, and he was started on, I think it was ramipril or amlodipine, I forget, and he started getting myelosuppression, and everyone was blaming it on the azathioprine. And actually, when you looked at the patient information on the antihypertensive, that also caused myelosuppression. So they stopped the antihypertensive, and his blood's completely recovered. So it's not always the thiopurine. I think it's obviously a red flag, but do consider any other medication changes. With hemoglobin, it also might be due to anemia for whatever reason. It doesn't have to be IBD related. So I would recommend doing a screen. So your hemoglobin index, looking at your iron, your folate, your vitamin B12, etc. For white blood cells, APS and platelets, Usinese, LFTs, exactly the same. Consider other recent medication, but if it's okay as per the shared care agreement, continue and monitor. And I normally recommend that they do bloods 2 weeks later. And if it's still a problem, refer back to the specialist team. However, if it's not within the shared care protocol guidelines, and again, it depends on which area you're in, don't hesitate, contact the specialist team to get that on. What we do sometimes see is teams telling the patient to contact the specialist team, and we'd really recommend that it should be the healthcare professional that's contacting the specialist team, so we can have that kind of informed discussion. And then you know that the patient's definitely done it. Some patients don't want to stop these medications, so they might not contact the specialist team. So it's really important that we make sure we're following up in a safe way. If a patient's got infection, so that's the one on the right-hand side, you're more than welcome to look at this. This is our trust website, and this obviously was very pertinent during COVID. So if it's a mesalazine they're on only, they can continue that through infection. It's no problem. If it's other medications and they feel unwell, for example, they have a temperature, they need antimicrobials, we'd recommend putting the other medications on hold. So that could be your thiopurines, or, if it's one of the drugs we use like infliximab, we'd tell them to put it on hold, or we might delay the infusion. And let the specialist team know, and also remind the patient that antimicrobials might make their IBD symptoms worse, because often they do affect the GI tract, and this, they give you symptoms, so you just got to be made aware that they might feel a bit rubbish for a week, but hopefully then the infection can go and they can restart their medication. In COVID, same situation, with regards to if feeling unwell, temperature, and needing antivirals, that they put them on hold. If it's more though about whether they get COVID treatment. So just to let you know, mesalazine, you don't get antiviral priority for COVID, but all the other medications, because they're counted as immunomodulators, they would get antiviral priority. And that's as per the latest release from the government as well that came out last month. If the patient is considering becoming pregnant, or is pregnant, or is wanting to breastfeed, I would recommend that they just speak to their specialist team straight away. The information in the patient information leaflet is very different to what we tell them. Generally, things are relatively positive within pregnancy and breastfeeding. I don't want to go into too much detail because things can change, and I know this is being recorded, but I would just recommend that you refer them to the specialist team, and we can give them the most up-to-date information. With regards to vaccines, basically for all the medications, all non-live vaccines are absolutely fine. They can go ahead and get all of them done. If they're on any immunomodulators, so anything other than mesalazine, live vaccines are to be avoided. And if they really need them, again, tell them to speak to the specialist team, and we can speak to our virologist to see if there's any wiggle room. And then the final thing, allopurinol. Now, we use allopurinol to actually manipulate the pathway with regards to thiopurines. And I'm sure you've all seen it, where we've dose reduced the azathioprine because we've added in allopurinol, and that's because of the levels. I won't bore you with it. But just to let you know, if you are seeing anyone on allopurinol, whether it's for gout previously or we've started it, that thiopurine dose should be reduced to 25% to 33%, so a quarter to a third of their previous usual daily dose, because if not, basically it becomes the equivalent of overdosing them on that thiopurine. So if you ever see allopurinol and you're not sure they've been dose reduced, again, do check with the specialist team, and we'd be happy to help there. So just to move away from patient X, we've kind of done everything we can. Patient Y, let's pretend they have Crohn's disease. And just to remind you, they should not get mesalazine. And if patients have been started on mesalazine because they weren't sure if it was ulcerative colitis or Crohn's, and then they get diagnosed with Crohn's, we will then look to stop the mesalazine. And then all the same thing that we've gone through is exactly the same for Crohn's. We're going to be looking at using steroids for flare treatment, and we're going to be looking at optimizing their medications. So for Crohn's disease, it's slightly different. If it's mild, we would use thiopurines, and due to a latest trial, if it's moderate to severe, so you get these advanced therapies a little bit earlier in the tract in Crohn's disease. So again, that might be something like infliximab, for example, plus or minus the thiopurines. So you might see basically more thiopurines for ulcerative colitis patients than you would for Crohn's. Some good resources. So as I mentioned, Crohn's Colitis UK really are excellent. And they've actually got resources for community primary care pharmacists specifically on there. So I've put the link up there. The Royal College of GPs, they've got a wonderful GP that is really passionate about this, and they've developed a toolkit for GPs. So, and I was using it when I was looking at this to try and make it as appropriate as possible. And it's really excellent. You can get access to it. There's a few things that are behind a firewall, but I could get access to most of it, and I've put the link there. And what's really good is the RCGP and the CPP have actually done a learning package together. And I think CCUK might have been involved as well. Now, I actually haven't had time to do this learning package. It's about 3 hours. So if people are really interested, please do check it out. And if you do have a local specialist team, do feel free to ask them questions. I try and answer all the questions I get through and try and be helpful as much as possible. So that's IBD. In my last 2 minutes, you'll be really pleased. I am not repeating all of that for autoimmune hepatitis. And the reason being is autoimmune hepatitis is one, super complicated, and two, is a really rare disease. So you're probably quite unlikely to come across it. So I just want to give you some very few pointers really about this. And a lot of them are actually mirrored from IBD, which is good news. For autoimmune hepatitis, that is an autoimmune disease of the liver where your immune system is attacking the liver rather than the whole gut like you get in IBD. And like IBD, steroids are a big treatment for that at the beginning stages. And we use very similar ones. The difference here is the steroid use can be slightly different doses, but that's not normally the problem. It's the duration. Sometimes these patients can need steroids for a year and a half, 2 years. So you might get prescriptions through your door that seem like ridiculous amounts of steroids. That is intentional, because what we don't want to do is the patient to run out, because if they run out, their autoimmune hepatitis flare risk is very, very high. And because of that, they should always definitely be on bone protection. They do get used. We do use immunomodulators with these. The guidelines recommend these: azathioprine, mycophenolate, and tacrolimus. Azathioprine's first line. Mercaptopurine isn't mentioned within the guidelines, but because we know that mercaptopurine is from azathioprine and we have a lot of experience with mercaptopurine, we do use it. So that's our first line of thiopurines, very much like IBD. And then we use mycophenolate and tacrolimus if needed. You know yourselves that, mycophenolate doesn't need to be brand specific, but tacrolimus does. So again, if you get a prescription, it doesn't have the brand on there, or if it's a different brand to what they've normally have, do feel free to query with the specialist team. And again, I think the same sort of issues would probably come up with autoimmune hepatitis, and it's slightly different. So that's what I wanted to focus on. Oh, sorry, I've said all that. Apologies. So, with regards to blood issues are very common with autoimmune hepatitis, particularly liver function going off and white blood cells and neutrophils going down. And they're normally because of the liver concern, the autoimmune hepatitis, rather than the drugs. So what I would say is, if you see any blood issues and it's an autoimmune hepatitis patient, don't stop the immunomodulator or the steroids, because actually that might make it worse. What you really need to do is contact the team straight away, and then we can just take it off your hands. The same thing with infections. If we stop the medication for the time an antimicrobial course would happen, they are likely to get an autoimmune hepatitis flare. So that's not to say we won't stop it, but I think don't feel like you have to make that decision. Contact the specialist team and we'll make that decision for you, and then put in the appropriate monitoring. Pregnancy and breastfeeding is a bit of a null point for autoimmune hepatitis, mainly because it affects kind of 50 to 60-year-old females, and so that's not normally an issue for pregnancy and breastfeeding. But obviously there are the exceptions. There are young women that do come through our door with this, and there are some men that obviously want to father children. So again, if there's any concerns or queries about that, just get them to speak to us. We'll go through that with them. And again, the same thing with allopurinol as there was with IBD. It's very much we need to dose adjust the thiopurines if allopurinol is being started, or if we're using allopurinol ourselves. So again, if you see allopurinol and it's not explained by us, do contact the specialist team and we can advise on dosings for you. So that's all I have to say about autoimmune hepatitis. I'm sure you're very relieved, in case you were thinking there's going to be another 15 slides on that. But it was just to kind of make you aware that it is different from IBD, and that actually, you know, the steroids and the immunomodulators, it's more difficult to stop, and actually stopping them could cause a flare, and so could be detrimental to the patient. So do contact your specialist team before you make any changes.